Hello, my geniuses. Welcome to another physiology lecture series today. It's a great science to Lorenzo, and today we're talking about glomerular filtration rate. So in my last video, we talked about the glomerular apparatus, and we have talked about the urine formation. So we want to talk about the glomerular filtration rate. So you watched my beginning video when I talked about the nephron, and I talked about glomerular apparatus. I talked about urine formation. So I'm now talking about glomerular filtration rate. So if you are just joining me, make sure to subscribe and turn on your post notification button, so at any time I drop any video, you'll be sure to be notified. If you want me to make a video for you, drop it down in the comment section. I promise I'll make that video for you when I see it. And if you want me to ask me any question, or you want me to explain anything special, you can send me a WhatsApp message on my video, on my number, so that I'll make sure when I see it, I will surely answer you to the best of my capability. So let us jump right into the video. So if we are to start with what glomerular filtration rate is, or we call it GFR, glomerular means the glomerulus. And where do you have the glomerulus? You have it inside the bone marrow capsule. So the glomerular, which is the glomerulus, filtration, which means to filter something, and rate, which we are talking about duration. So the glomerular filtration rate, we call GFR, is the rate at which the content of the blood is filtered through the glomerulus at a specific period of time. So at a rate which is a duration, a specific period of time, the rate at which the content of the blood, which is the content inside the glomerulus, is filtered to the glomerulus of the kidney. Again, the glomerular filtration rate is the rate at which the content of the blood is filtered to the glomerulus of the kidney at a particular period of time. Now so naturally blood move to the afferent arteries of the kidney. Are you getting me now? So the renal artery has an arterial. So we have the afferent arteries, we have the efferent arterial. Blood enters through the afferent arteries and leaves to the efferent arterial. So the amount of blood that enters through the afferent arterial is being filtered through the glomerulus capillary. So they have a glomerular capillary. A glomerular capillary is a fenestrated capillary. So we have a continuous capillary, we have a discontinuous capillary, we have a sinusoidal capillary. So a glomerular capillary is a discontinuous capillary where you have a fenestration point where fluid can leak in from the blood vessel into the bone marrow capsule. You get it? So now the rate at which blood is filtered to the kidney for it to be reabsorbed or it to be eliminated as urine is called the glomerular filtration rate. And for the normal value of the glomerular filtration rate is about 125 ml per minute. So per every minute you have 125 ml of blood is being filtered every minute. So the total amount of blood that is coming to the afferent artery is about 1300 ml. I get it. So 1300 ml is coming from the afferent arterial, and per every minute you have what you call 125 ml is being filtered. You get it now. So you can see the diagram of the renal corpuscle. The renal corpuscle is made up of the bone marrow capsule and the glomerulus. So the glomerulus and the bone marrow capsule make up the renal corpuscle. So you see the glomerulus is inside the bone marrow capsule. So when blood enters to the afferent, you can see the arrow. When blood enters into the afferent, it leaves to the glomerular capillary into the bone marrow capsule. So the liquid that cannot enter will leave to the efferent arterial. Again, so we want to look at how we can regulate and make sure that useful materials are being filtered into the kidney. Because if they are not filtered, they will be left out and they will roam around through the blood. And when they roam around through the blood, or remember we have waste product, and waste product has to be eliminated from the kidney. If not, they will be high in the blood, and when they are high in the blood, they are toxic to organs, and when they are toxic to organs, they can destroy various organs. So it is a very, very indicator for kidney function. So GFR is a very, very indicator for kidney function. So let us look at the pressures that are important for glomerular filtration. So what are the pressures that are important for glomerular filtration? Number one, GFP, which is glomerular filtration pressure. So we call it glomerular filtration pressure, we call it capillary hydrostatic pressure. So the capillary hydrostatic pressure, we call it the glomerular filtration pressure, is the pressure needed to filter blood from the glomerular capillary. The pressure needed to filter blood from the glomerular capillary, because when blood is entering into the afferent arterial, it enters into the glomerular capillary. So you have to increase the pressure of the what filtrate so that they can enter to the what glomerular capillaries. So if the pressure is low, which means as blood is coming to the afferent artery, it cannot be pushed into the what glomerular capillary. So we have to increase the capillary hydrostatic pressure so that the fluid can leak to the what glomerular capillaries. And approximately the pressure should be 60 mmHg, which is between 45 to 70 watt mmHg. So the range of the pressure needed to push all the filtrates inside the what glomerular capillary into the bone marrow capsule should be between 45 to 70 mmHg. The average is 60 mmHg. So when you increase the capillary hydrostatic pressure or the glomerular filtration pressure, what happens? It will increase what? Filtration. The next one is colloidal oncotic pressure. So this is the pressure exerted by plasma proteins, because naturally plasma proteins are present in the blood. And so why is there plasma proteins? Plasma proteins is inhibiting excess fluid or excess water to enter or to pass through the what? Kidney. Are you getting it now? So naturally it is constant throughout the blood. Plasma proteins are very, very important. They prevent edema, because without plasma protein, what happens? All the whole fluid will leak into your what? Tissues. So plasma protein helps to regulate and only allow useful materials that are useful to the blood to enter into the tissues, like oxygen, ions like sodium, calcium. These are the only compound like the plasma protein can allow to pass through the what glomerular capillaries or any of the what capillaries that are in the tissues, because majorly all arteries enters into the tissues and forms a capillaries, which means oxygen enters into the capillaries and enter into the tissues, while the tissues release CO2 and other waste products into the blood to go out to the venous system or into the lymphatic drainage. You get it now? So at this particular point, the colloidal oncotic pressure offered by the plasma protein helps you to keep fluid inside the blood and also prevent fluid from leaking into the tissues, because when the colloidal oncotic pressure reduces, fluid from the blood will enter into the tissues, causing what? Edema. So the colloidal oncotic pressure is the pressure exerted by plasma protein, and it is constant, which is 25 mmHg. So it opposes filtration. So as the capillary hydrostatic pressure is increasing filtration, colloidal oncotic pressure is reducing filtration, but only allowing useful ionic and non-ionic substance to pass through. But it doesn't allow compounds that are very, very big. So plasma proteins are very, very big. Are you getting me now? They are very, very big, so they cannot pass through. They cannot pass through. It is only those that can pass through, which are ions and non-ionic compounds like glucose, electrolyte like sodium, calcium, that can pass through. The last one is what? Capsular hydrostatic pressure. Capsular hydrostatic pressure are pressure exerted by the what? Filtrate in the bone marrow capsule. So they are filtrate in the bone marrow capsule. So when filtrate passes through and enter the bone marrow capsule, so that they will journey to the PCT, Hennis lobe, DCT. So the pressure, there's an upward pressure in the bone marrow capsule, preventing excess amount of what? Fluid to be filtered from the what? Glomerular capillary. So the bone marrow capsule exerts an upward and an inhibiting pressure. So the bone marrow capsule is almost equal to the what? Colloidal oncotic pressure. So the colloidal oncotic pressure is inhibiting the capillary hydrostatic pressure, same as the capsular hydrostatic pressure. So the capsular hydrostatic pressure is inhibiting the what? Capillary hydrostatic pressure, because when excess amount of fluid is entering into the bone marrow capsule, there's a negative feedback mechanism that is telling the capillary hydrostatic pressure to inhibit and not to allow excess material to enter into the kidney. So it is just like a regulatory system. You get it now? So capillary hydrostatic pressure, his work is just to filter. It doesn't care how much it is that is entering into the kidney. You get it now? It doesn't care. It's only just to filter to the glomerular capillary, inside the bone marrow capsule. So when it is not high inside the bone marrow capsule will now try to inhibit using its what? Capsular hydrostatic pressure, and it's about 15 mmHg. So we have capillary hydrostatic pressure, which is a positive pressure, colloidal oncotic pressure, which is a pressure offered by plasma protein, which is negative, while what? Capsular hydrostatic pressure, which is also opposing what? Capillary hydrostatic what? Pressure. To summarize the pressure needed for glomerular filtration rate, number one, we have the capillary hydrostatic pressure, or we call it glomerular hydrostatic pressure, which is 60 mmHg. It promotes filtration. You have the colloidal oncotic pressure, which is the pressure offered by what? Plasma protein, which is 25 mmHg, is constant throughout the blood. And we have the capsular hydrostatic pressure, which is 15 mmHg, which does negative feedback, inhibiting the capillary hydrostatic pressure. So hope you understand what I've said here. So the next one now is what we call the net filtration pressure. So we have talked about the capillary hydrostatic pressure, the colloidal oncotic pressure, the capsular hydrostatic pressure, and now we are talking about the net filtration pressure. The net filtration pressure is the balance between the capillary hydrostatic pressure and the opposing pressure. The balance between the capillary hydrostatic pressure and the two opposing pressure, which is the colloidal oncotic pressure and the capsular hydrostatic pressure. So to get the net filtration pressure, we have to get the difference between the capillary hydrostatic pressure, which is CHP, and the sum of the colloidal oncotic pressure and the capsular hydrostatic pressure. So now, what is the capillary hydrostatic pressure? The capillary hydrostatic pressure by our calculation is 60 mmHg by average. I get it, my 60 mmHg by average. While the colloidal oncotic pressure is 25 mmHg by average, and the capsular hydrostatic pressure is 15 mmHg by average. So when you add 25 plus 15, it will give you 40. So 60, which is the capillary hydrostatic pressure, minus 40, which is the sum of the colloidal oncotic pressure and the capsular hydrostatic pressure, will give you what? 60 minus 40 will give you 20, which is the net filtration pressure is 20 mmHg. So the higher the capsular hydrostatic pressure, the higher the net filtration pressure. So when you increase the capillary hydrostatic pressure, the net filtration pressure increases. You get it now? But when you increase the opposing pressure, when you increase the colloidal oncotic pressure, or you increase the capsular hydrostatic pressure, what will happen? It will do what? There will be a drop in the net filtration pressure. So this was affirmed by Frank-Sterling's hypothesis. So because in Frank-Sterling's hypothesis, this says that the net filtration pressure to the capillary membrane is directly proportional to the capillary hydrostatic pressure minus your oncotic pressure. So this net filtration pressure was confirmed, and it was confirmed by the Frank-Sterling's hypothesis. And what does it say? I can repeat again. It says that the net filtration pressure to the capillary membrane is directly proportional. Like I said, always remember, I told you that the net filtration pressure is directly proportional to the capillary hydrostatic pressure, because if you increase the capillary hydrostatic pressure, you are increasing the net filtration pressure. But when you increase the oncotic pressure, what are you doing? You are decreasing the net filtration pressure. So Frank-Sterling hypothesis is a very, very important hypothesis. So you see also Frank-Sterling hypothesis in the factors affecting cardiac output under the force of contraction, and you also see it in when we explain edema. So in edema, it's very, very important. So if you increase your capillary hydrostatic pressure, what happens? There will be more fluid that is leaking into the tissues. But to counterbalance it, you have to also make sure that your oncotic pressure is at balance, because when you reduce oncotic pressure, the capillary hydrostatic pressure will be high. So naturally, that is why the net filtration pressure is 20, because when you reduce the colloidal oncotic pressure, much more fluid will be leaking into the tissues, and there will be no restriction for the fluid to be stay in the blood. If not, it will enter into the tissue and it will not be able to pump back into the blood through the venous circulation. So here you will see now we have what they call filtration coefficient. So what is filtration coefficient? Filtration coefficient is the ratio of GFR to the net filtration pressure. So we have talked about Frank-Sterling's hypothesis, we have talked about the net filtration pressure. So when you are getting the ratio of the GFR to the net filtration pressure, you get what we call filtration coefficient. Are you getting now? So now Kf, which is the filtration coefficient, is equal to GFR over net filtration pressure. So the GFR is 125 ml per minute, while the net filtration pressure is 20 mmHg. So if you are getting the filtration coefficient, you'll be getting 6.25. I get it. So the net filtration pressure here is 6.25. So you always remember here. So we have three pressure. You have the capillary hydrostatic pressure 60, you have your colloidal oncotic pressure 25, and you have the capsular hydrostatic pressure 15. So when you get the difference between the capillary hydrostatic pressure and the sum of the capsular and the colloidal oncotic pressure, you get the net filtration pressure. So when you say the net filtration pressure is directly proportional to the capillary hydrostatic pressure minus the colloidal oncotic pressure, while the ratio of the GFR to the while the ratio of the GFR to the net filtration pressure gives us your filtration coefficient. So the filtration coefficient is constant for every kidney, which depends on the surface area and the permeability of the filtration membrane. Because when you increase the surface area, you increase the GFR and also the permeability. So when at a constant permeability and also the surface area, the net filtration pressure will be constant. So hope you have understand. So we want to look at the factors affecting GFR. Number one, renal blood flow. So what is the renal blood flow? Is it directly proportional or is it inversely proportional? So the renal blood flow is directly proportional because why? When you increase blood flow to the kidney, which means you are taking the component of the blood to be filtered so that they can be reabsorbed. Because what is the function of the kidney? The function of the kidney is reabsorption. So which means anything that escape absorption, because after absorption in the intestine, the blood is going to the liver for metabolism. So any fluid that escapes that do not go to the liver will be reabsorbed by the kidney back into the blood. So when you increase renal blood flow, which means you are taking a large amount of blood to be filtered into the kidney so that they can be reabsorbed. Are you getting me now? So an increase in renal blood flow to the renal arteries increases the quality that will be filtered. So I told you that is 130. I told you that is 1,300 ml that is being filtered. Are you getting me? So when you increase the renal blood flow, you have increased GFR because you will be donating more blood that will be filtered from the glomerular capillaries, and more blood that will be reabsorbed by the kidney. Number two, constriction of the afferent arterial. So if you constrict the afferent arterial, what will happen? Remember, for you to increase renal blood flow, you have to dilate the afferent arterial. Are you getting now? For you to increase renal blood flow, you have to dilate the afferent arterial. And if you dilate the afferent arterial, you have increased renal blood flow. And when you increase renal blood flow, you have increased GFR. But if you constrict the afferent arterial, what happens? You will decrease GFR. That's why I will say the constriction of the afferent arterial is inversely proportional to the GFR. It's inversely proportional. Very, very interesting. Why? Because constricting the afferent artery inhibits blood from entering into the renal capillary. Inhibit blood from entering into the renal arteries. So if renal arteries or the renal arteries is not taking blood, there will be less amount of blood that is entering into the glomerular capillary, which means it will decrease GFR. So dilation increases GFR by increasing renal blood flow, while constriction decreases GFR by decreasing renal blood flow. Constriction of the efferent arterial. So if we constrict the efferent arterial, what will happen? Naturally, for us to keep blood into the renal capillaries or into the glomerular capillary, we have to close a little bit the efferent arterial. If you open the efferent arterial, which means as blood is coming in from the efferent arterial, entering into the capillary, it will be leaving to the efferent arterial. So do you know what we do? We close the efferent arterial a little bit so that the blood can take time. It will be increase in contact time, increase in staying time in the capillary. So when there's increase in contact time and staying time in the capillary, more blood will enter and be filtered. And if they are filtered, it will increase GFR. So we need to constrict the efferent but dilate the afferent. You get it now? So if you now dilate the efferent, what happens? Blood will leave and it will decrease GFR. So dilation decreases GFR, while constriction increases GFR. Surface area. So the surface area is directly proportional to the GFR. Are you getting now? But in renal disease, when the surface area is reduced, the GFR will also reduce. Remember what happens. For you to filter, you have to increase the surface area. Why? So that much more ionic and non-ionic substance will find way to get filtered. Are you getting now? So but when you reduce surface area, it will be that it will take time for most of them to pass through. Why? Because they are much more, the fenestration capillary will be very little. But when you increase the surface area, there are much more fenestrated capillary, much more holes for all these ionic and non-ionic substance to enter. And when they pass through that holes, what happens? They will enter into the bone marrow capsule. So we need to increase the surface area so that most of them can diffuse freely. But in renal disease, in the sense of when there's inflammation of the glomerulus, like in glomerular nephritis, when most of the capillaries are permeable, not even in glomerular nephritis, especially in some conditions whereby most of the fenestration capillaries are already closed, and when they are closed, you are reducing GFR because you are reducing the surface area. Arterial blood pressure. Remember autoregulation I taught you in cerebral circulation and coronary circulation. Here the kidney can regulate its blood pressure between 60 to 180 mmHg. 60 to 180 mmHg. Above 60, above 180 and below 60, the kidney cannot regulate itself. Are you getting now? So when you increase the renal pressure, when you increase the pressure, what happens? You are decreasing GFR. When you increase the pressure, why? Because you are constricting the afferent arterial. Constricting the afferent artery means that increasing peripheral resistance. When you increase peripheral resistance, you increase pressure. And when you increase pressure, you will reduce renal blood flow and you drop GFR. Do you understand it now? Remember, I said constriction of the afferent artery does what? Decrease renal blood flow. And when you decrease renal blood flow, you decrease GFR. So when a patient has increase in blood pressure, like in what hypertension, what happens? There will be a decrease in GFR. Because you know what, the body will be sure that there is a decrease in GFR because there is much more fluid inside the blood. The body will not start decreasing GFR, but therefore start inducing renin-angiotensin pathway. Why? Because it feels that there's no reabsorption, and since there's no reabsorption, it will now start inducing renin-angiotensin. So when you are inducing renin-angiotensin, there will be vasoconstriction of the blood vessel, increasing what? Blood pressure. Because during hypertension, there are much more during hypertension there are much more electrolytes in the blood. Sodium, calcium, there are much more electrolytes in the blood, which is reducing peripheral resistance. And anytime you reduce peripheral resistance, what happens? You are increasing blood pressure. And at the same time, what happens? The body does what? Constrict the afferent artery to reduce renal blood flow, to reduce GFR. But if you decrease blood pressure, what are you doing? You are vasodilating the blood vessel, reducing peripheral resistance, increasing blood flow, increasing GFR. So increasing blood pressure, decreasing GFR, reducing blood pressure, increasing GFR. Are you guys getting now? So always that the blood pressure of the kidney can be regulated between 60 and 180. Are you getting now? So within that range, the kidney can regulate its blood pressure, but below or above it, it cannot, and it will cause issues in your GFR. It will cause issues in how the kidney filters and how it reabsorbs blood. The next one is what? Capillary hydrostatic pressure. So for you to have filtration, you have to increase in the capillary ability for it to filter. If the capillary is not filterable and it cannot filter any substance, you know what? You are decreasing GFR. So when you have increase in capillary hydrostatic pressure, is directly proportional to GFR. Why? Because every content that enter into the glomerular capillaries will be filtered. So increase in glomerular hydrostatic pressure will increase what? GFR, by allowing more components to be filtered from the what? Glomerulus. Colloidal and oncotic pressure. Remember, colloidal and oncotic pressure is the pressure offered by plasma protein and is inversely proportional. And since it's inversely proportional, which means that an increase in plasma protein will increase peripheral resistance. When you increase peripheral resistance, we increase blood pressure, we drop GFR. You get it now? So you see the connection. Increase in oncotic pressure decreases GFR by what? Opposing capillary hydrostatic pressure. So if you oppose capillary hydrostatic pressure, it will also increase solute in the blood by increasing peripheral resistance. You get it now? So we have, when you have increase in plasma protein, like how hyperalbuminemia, I get to hyperalbuminemia, hyperglobulinemia, when you have increase, or hyperproteinemia. So when you have increase in protein in the blood, it will increase peripheral resistance, dropping what? GFR. Capsular hydrostatic pressure. Capsular hydrostatic pressure is inversely proportional to GFR. Why? Because it opposes capillary hydrostatic pressure. Why? To inhibit the amount of substance that is entering. Take for instance, there is increase in GFR. The capsular hydrostatic pressure will say, wait, reduce the amount of what is entering. So it is a negative inhibitor for what? Capillary hydrostatic pressure. So it is almost the same thing with colloidal and oncotic pressure. So colloidal and oncotic pressure is opposing capillary hydrostatic pressure. Capsular hydrostatic pressure is opposing capillary hydrostatic pressure. So it is inversely proportional to the GFR. So when you increase capsular hydrostatic pressure, you are dropping the GFR. Why? Because you are telling substance to not enter into the bone capsule. Permeability of the capillary membrane. Are you getting now? So if you want to filter, you have to make the glomerular capillary to be permeable. If they are not permeable, what happens? It cannot pass through. It cannot pass through. So go and watch my video on the glomerular capillary. The glomerular capillary, I told you, is that the basement membrane of the blood vessel pierce the basement membrane of the glomerulus, like fuse it with the basement membrane of the visceral part of the bone marrow capsule. So when they fuse, they create a space so that anything that passes through the glomerulus will enter through the visceral part of the bone marrow capsule into the bone marrow capsule. You get it now? So the bone marrow capsule has a visceral part and a parietal part. The basement membrane of the visceral part fuses with the basement membrane of the what? Simple squamous epithelium, which is the glomerulus, so that fluid can pass through. So if you want to allow things to enter, you have to make them permeable. If they are not permeable, they cannot enter. Sympathetic stimulation. So what does sympathetic stimulation do? When you increase sympathetic stimulation, what happens? The body releases what? Catecholamines. So when you increase catecholamines, what happens? Especially epinephrine and norepinephrine, what happens? It will bind to alpha 1 and what? Alpha 2. It will bind to alpha 1, alpha 2, beta 1. It will bind to alpha and beta receptor. So when they bind to especially alpha receptor, because we don't want beta here, beta binds to what? The heart. So we are looking for norepinephrine. Norepinephrine is binding to alpha. So when it binds to the alpha in the what? Afferent arterial, what? It will constrict the afferent arterial, especially during what? Fight or flight. During what? Stressful condition, when your body is releasing norepinephrine to vasoconstrict your blood vessel. So if you vasoconstrict the renal what? Artery, especially the arterial, what will happen? Vasoconstriction will do what? Reduce renal blood flow, reducing GFR. I get it now. So catecholamine will be released, especially which part of catecholamine? Norepinephrine. So if it's released, what happens? It will bind to the alpha receptor on the what? Afferent arterial, reducing the what? Renal blood flow by increasing the peripheral resistance. If you increase the peripheral resistance, you increase the blood pressure, you drop GFR. You get it now? So you see this now. Sympathetic stimulation drops GFR by increasing norepinephrine, which binds to the alpha receptor on the what? Renal arterial. So if you bind to the alpha receptor, it causes vasoconstriction, reducing renal blood flow, which reduces what? GFR. Hormones. What are the hormones that increase GFR? Every hormones that vasodilate the blood vessel will increase GFR. If you vasoconstrict the blood vessel, you increase peripheral resistance, you increase pressure, you drop the renal blood flow, you drop GFR. So what you have to do here, for this connection, you have to vasodilate the blood vessel so that more blood will enter into the what? Renal arterial. So what are the hormones that vasodilate? Histamine is a vasodilatory endotoxins. Prostaglandin 2 is a vasodilatory 2 prostacyclin, the vasodilate the blood vessel, and also PGE2. You have antidiuretic peptide, they also vasodilate. You have bradykinin. Bradykinin is a vasodilating toxins also. You have dopamine. Dopamine is an inhibitor, so it will vasodilate the blood vessel. Adenosine too. Adenosine is gotten from when ATP is broken down to ADP during stressful condition, because every day you burn ATP. If you burn ATP, you use up ATP. When you use up ATP, it goes to ADP and it goes to adenosine. And what does adenosine do? Adenosine is a what? It's a vasodilator. It vasodilates the blood vessel and increasing what? GFR. So what are the hormones that reduce GFR? Any hormones that vasoconstrict the blood vessel reduce GFR, e.g. platelet activating factor. You have serotonin. You know serotonin is a prominent vasoconstrictor. Angiotensin 2 is a prominent vasoconstrictor because it binds to what? The adrenal medulla, increasing norepinephrine. Epinephrine to vasoconstrict the blood vessel to a greater amount. Norepinephrine and vasopressin, which is ADH. These hormones reduces GFR. So the next one is regulation of GFR and what? Renal blood flow. You get it now? Regulation of GFR and renal blood flow. So do you know what I will do? I will take it to the other video here, so that will not contain all the space here. Again, so you can watch it in the other video because it's very you just stay with me, watch the introduction to GFR here and the factors affecting GFR, and in the next video you'll be watching the regulation of what? GFR and renal blood flow. It's very important. So hope you have understood everything I've talked about. When we introduce what GFR is, where we say GFR is the rate at which the content of the blood is being filtered, and we say it is 125 ml per minute, and we say the GFR is a great indicator for what? Kidney function. And we go further to talk about the pressure of the glomerular filtration. We go further to talk about the glomerular filtration rate pressure, the pressure that increases or that contributes to glomerular filtration rate. Talked about the capillary hydrostatic pressure, the colloidal oncotic pressure, and the capsular hydrostatic pressure. So the capillary hydrostatic pressure promotes filtration, while the colloidal oncotic pressure and capsular hydrostatic pressure inhibit what? Filtration. You get it now? So we also talked about the net filtration pressure, which is the capillary hydrostatic pressure minus the colloidal oncotic pressure plus the capsular hydrostatic pressure. which was supported by Feinstein's hypothesis. We also talked about the filtration coefficient and the factors affecting GFR. So hope you understood everything we have talked about here. Hope you understood it 100%. You get it now. So if you are new to my channel, make sure to subscribe and turn on your post notification button so that anytime I drop any video, you'll be sure to be notified. If you want me to make a video for you, drop it down in the comment section. I promise I'll make that video for you. So we'll go into the next video, which is the regulation of the renal blood flow and the glomerular filtration rate. Bye bye.